Thank you. Okay, so let me introduce what we're trying to do in our conversation today. The Physician Innovator, the initiative, and the website and my work all together are focused on a very particular form of innovation. And briefly, that form of innovation is when a small but full-time clinical team redesigns care and delivers improved care for a very particular patient population. Now, that's a pretty narrow focus in a wide, wide world of innovation. So let me very briefly say why this is such an interesting type of innovation to focus on. Number one, these innovations can be very powerful, and as I like to say, as powerful as penicillin. The magic of penicillin is that it delivered a double win way back when, both lowering costs for the system as a whole and keeping people healthier. Very few new pills or new devices do that anymore, but these innovations do. Second, they're based on very simple principles. You'll never hear us on this forum talking about cutting-edge biosciences or the latest implantable devices. We talk about simple principles like keeping people healthy, like coordinating care, and new clever mechanisms for doing better in those areas. Third, we're talking about innovations that are interesting because they're not sort of bet the farm kinds of innovations. They involve modest risks and modest investments. Fourth, because they've been overlooked for so long, largely because the payment model, fee-for-service, so often stands in the way. And finally, I'm interested in this form of innovation because there's so many opportunities, literally tens of thousands in the US alone. So what is this initiative called the Physician Innovator? Well, I see it as a platform for sharing insights and experience among the clinicians, mostly physicians, who are leading these efforts. And I'm very pleased to introduce now one of those physicians, Dr. Robert Graham from Boston Children's Hospital. And Rob, if you're ready, would you please go ahead and turn on your webcam?
Hi. Hello to everybody.
Rob, thanks so much for being here today. We're so pleased to have you. One of the things I'm happiest about is that people already have read a bit about you, so we can skip right past some of the basics of who you are and what you do. We know that already. And to kick us off, what I'd like to do is simply ask you to ground us in your reality this week. What's going on today, this week, or this month? Maybe tell us about the patient load you're dealing with these days as a way to begin.
Yeah, so to be perfectly honest, I think we're all sort of recovering from a late flu season. For those who are clinically active in the audience, I'm sure you're feeling the same. This is both in terms of our work with the patients and then the families are literally recovering themselves. It has been a long, long winter. So I think that's sort of the most acute issue. And then honestly, it's sort of the day-to-day stuff that we do. To give you a sort of an example, I was out on home visits yesterday. Had one young lady in her late 20s with an advanced mitochondrial disorder who's planning a trip to Italy next week. She's never been on a plane. She's ventilator-dependent, and sort of trying to set up all the contingencies for that trip. And as you can imagine, there's a lot of angst around that, both in terms of logistics and then contingencies. So, that was one of the visits yesterday, and then some more routine things, just in terms of health maintenance for others. And, I have to say every visit's sort of a surprise. Actually, we did have our first visit yesterday was a young lady who's been on sport for years. She got a new piece of equipment. For those who know, it's a cough assist device, the new portable battery-operated one. She's had the same one for 20 years and didn't feel that the new one worked as well. And in fact, when we went out to test it, sort of pointing out the value of the home visit, in fact, it wasn't working. They had delivered her a defective device. So thankfully, she had the old one that everyone talks about as sort of the workhorse, has always been there.
Thanks, Rob. Those are certainly the types of stories that make it real. And I've got a picture of your patient getting on an international flight for the first time, and it must involve a great deal. Let's take a step back and give us a bit of a broader perspective of what's most preoccupying now in terms of the program as a whole and where you'd like to take it in the coming months or the coming years.
Yeah, so I mean, I think, as I think, we're globally we've had periods where we've been able to be a little more proactive in our management. Unfortunately, as the program has grown, I think we've reverted back to what I call more of a reactive model, where especially as we look at this winter, we were sort of just waiting for the next call. So-and-so has a fever, so-and-so's, up on their support or there are other issues. As I look to sort of scale the program, and we'll talk about sustainability, we've sort of reached a capacity in terms of our patient load and our staffing. And as a result, I think what we've done is we're literally just sort of putting out fires and don't have as much time to really sort of do that preventative outreach that we'd like to do.
So let's go to the delivery model itself. Rob, I've got a lot of interesting questions from the audience in advance that are curious about how care is delivered by your team day to day. And there's a particular interest from the audience in telemedicine. And let me say now to the audiences, we're ready to take your questions. If you have one, raise your hand or type into the chat box. We're going to focus first on the specifics of the delivery model, delivering care. And Rob, let's start with telemedicine. I know this is a recent thrust within your program and that you're pretty pleased with the early results. Tell us about what you're doing.
Right. So, yeah, we had a small internal grant, which my colleague Dave Cassavant was able to procure for sort of innovative models. And our hospital is actually committed to, one of the HIPAA-compliant platforms. So we've started to use it. As I said, we want to use it in a preventative mode just for routine visits, but we also sort of see the value of the telemedicine for the acute visits, for the, the calls that say there's something not right or this alarm is going off, can you take a look at my child? And, part of our, we're in New England, but as I look at sort of the audience out there, obviously we actually have relatively small geographic sort of catchment, but if you're looking at other parts of the country, the distances are quite far, and I think telemedicine is going to be invaluable for us and really has a great potential elsewhere, where you don't have to send someone in to a hospital or to their local urgent care, or otherwise you can do some remote assessment, and even as you said, sort of walking families through ventilator adjustments, or if it's an alarm issue and it's just sort of internal menus on some of the devices, or actually just watching their respiratory pattern, sort of trying to see what a rash looks like. Those are some of the things we've utilized it for, and it really has been invaluable. And to be perfectly honest, one of the things we found, one of our concerns going as we embarked on this, was would people be amenable, and would they have the technology? And independent of people's resources, though everyone has a smartphone or everyone has a computer that has an eyeball on it, it really has not been an issue, even for those with the, sort of the lowest amount of financial resources.
One of the things that I learned in getting to know you and your work, and that may be new to some of the clinicians on the line even, is just how much innovation there's been in ventilator devices and how sophisticated they've become. So I can imagine troubleshooting over a video connection might be a really attractive option.
Yeah, no, it is. It's very helpful, and I have to give credit to my respiratory therapist that's on our team. Is she's really sort of embraced this as well, because the call at in the evenings or on the weekends when an alarm won't stop, the default is to manually ventilate someone, bring them into the local ER, and then it sort of starts a cascade from there. Interestingly, actually, our social worker on our team is actually looking to start piloting this for some teletherapy for families. As we sort of think about our preventative measures, it's everything else around the medical care that I think sort of affects outcomes. And so our social worker is sort of looking to pilot this and do some therapy sessions with parents, look at other stressors, actually do some mental health care. And our feeling is telemedicine may be a great platform for that, simply because of the time. I mean, these families don't have the time to step away, to leave home, and do an hour session outside of the home with the transit time on either side away from their child necessarily, and that this may be, again, a perfect sort of platform for that.
Changing topics just slightly, Rob, I have another interesting question in advance of our call today about EMTs and whether you're able to proactively coordinate the way they respond to your set of patients.
Yeah. No, it's, as we, if I have my home base is in the ICU, and if I have a new family going home or a family that we know that's just integrating new technology, whether I follow them or not, actually I always recommend they reach out to their local providers. I just think it's a prudent thing to do for everybody involved. And so we will, we sort of reach out to them and say, here's an introductory letter. We actually encourage them to invite the local first responders into the home to begin with, to meet the child, but also to see what type of supports they're on. And then we have actually held some sort of in-services with local providers as well to help them understand what it is that they're on. We always talk about with families having an emergency go bag, bringing with them, if they're going with EMS, what they would standardly use. It is important because, most of our first responders are, going to be adult-oriented, and sort of the home technologies, as you suggested, are far more complicated than they used to be.
Thank you, Rob. And a similar question, but there's a lot of interest in how regular primary care can be better positioned to work with the patients that you deal with every day. One of the common struggles that you're dealing with is that primary care physicians may not know what to do and therefore escalate these cases more readily than they need to be escalated.
Yes. It's funny. I always emphasize with the families that, first of all, you have to have although I do a lot, and our team is actually quite, we try and cover as many issues as we can, that they need a primary care coordinator, and they need someone local just to check the ears, to do routine vaccinations. And while, yes, I bring out flu vaccine, and yes, we administer Synagis sometimes in the home, especially for my patients who are living up near the Canadian border or elsewhere, they need a local provider. And we reach out to them and ask that the families ask them to reach back to us. And I have to say, uniformly, the primary care wants to be involved, and most of it is just either needing to be brought up to speed on the given condition, and certainly brought up to speed as to what the limitations and with regards to what type of technology are they on, when do they need to be seen, what can be done locally, and when do we want to refer down. And so we've tried to develop a network of pediatricians who are amenable and maybe are adapting their own practices for some of these complex kids. But it's definitely critical, for our kids to have some local supports.
Rob, going to another question that came in before our event. As a veteran of watching innovations within established organizations across any industry, one of the complications is always there may be multiple groups that are doing something similar or related. And I wonder if you've run into that at all at Boston Children's, where you've had to coordinate with groups that touched on care for your patients in one way or another.
Yes, we definitely overlap. There's, prior to me sort of stepping in and saying, A, I'm interested, B, I want to do something, it's funny, we talk about novel. The home visits aren't novel, it's just that we've gotten so far away from them, that sort of coming back to that. These children were getting cared for before, and what I've tried to do is say, this is what we're adding. And, definitely, A, you don't want to sort of steal patients or otherwise. And we do collaborate and overlap with a lot of the services. Some people have said, in fact, actually, I think you guys provide a more comprehensive service. Others I sort of partner with and say, how do we augment what you're already doing? So for some of our pulmonary providers who already have followed children on a home vents, we say, you're the primary point person, but perhaps we can help by doing a home visit, making sure things are as you might want them to be, and then reinforcing teaching with the home nurses or otherwise, and just sort of partnering from there. So yeah, definitely, we try and, play in the sandbox, as it were.
Looking at some of the questions that are coming over on chat, I think there's a lot of interest already in moving towards the how do we make this type of care work financially sort of topic. And that's always an interesting one. You've got a great team. Everybody in the audience has read about how that team works. But how do you pay for it? And let's start with how you got the program started.
Yeah. I have to say this was sort of a fortuitous, timing, I guess. I've had this interest as I did my pediatric training and critical care training, and then spent time working at a local rehabilitation hospital, sort of seeing where the overlap was, or where actually there was sort of a deficit in the transitions home, the sort of the returns to the hospital, and knew sort of who in the area was taking care of these children and their families, and reached out to a respiratory therapist from our hospital who was actually kind of just doing the right thing, as she saw it, is that on her way home or when she was out in the community, she would stop by and see some of these kids just to check in. And so that, she was helping them when they were in the hospital with teaching and wanted to make sure that there was some throughput. So I reached out to her and said, do you want to codify this, make it a little bit more formal? And I went to my division chief and department chair, and again, I think they saw at face value that it was important, and I think they also were able to take a little bit of the long view as they saw what was happening in the hospital at that time in terms of capacity, complexity, and lengths of stay. And so, they gave us some initial support. We rapidly sort of reached our own capacity in terms of, again, volume, but also appreciated that we didn't have everything that the patients and families needed. As a physician, although I like to think I, can cover a lot of issues, and with the respiratory therapist, it was the other needs, the sort of social and supportive needs that we weren't addressing. So I went, Boston Children's had a partnership with several of the payers, and we'll talk about how grant support plays into this, but they had created a grant mechanism for quality improvement, and we're looking to support new programs. And so I went to them with a proposal to increase our staff, so look to add a social worker, add a nurse practitioner as we looked at different models, and allow for some administrative support. But in parallel with that, look at some give us a mechanism to look at some outcomes. So look at resource utilization, some family-centered outcomes, and patient-centered outcomes, and move forward with that. And with that, we were able to, as I said, expand the number of patients and also the breadth of our care, and go forward with that. That lasted for about 3 years, which was great. It also helped us engage with the insurance companies, and we've been able to sort of continue it to an extent on some side grants, with the insurance companies actually are trying to look at what type of mechanisms are possible for a small program. So we have one payer who's, we have 25 of their patients. How do they carve out a support mechanism or a payment mechanism for 25 of their enrollees, where they may have, hundreds of thousands, if not, more, millions of enrollees? That's a challenge. The grant mechanisms, as I said, while it's been phenomenal, and I greatly appreciate all the support we've had, it's not a sustainable model, and it certainly doesn't allow for scaling. And this is the challenge, is that I see it as sort of a means for us to demonstrate, efficacy, to then work with the third-party payers and the federal payers, for that matter, and state payers, to look at other mechanisms, because I see that as really the only way to go forward for any of these types of programs.
The pattern that you're describing is one that certainly I've seen in lots of different healthcare contexts. You've got a team that delivers services that deliver the double win that I described earlier. Patients are healthier and happier. Money is saved for the system as a whole, and yet you have to talk about grant funding or perhaps support from a senior executive that's really committed to the program in order to sustain it. The future, we hope, is much more broadly spread accountable care contracts or risk-sharing contracts, and I wonder if you can give us some thoughts or updates on where you are with respect to new kinds of contracts and where you might be going.
Yeah, so I mean, it's true, and again, I have to thank my department chair has been phenomenal. I mean, we are utilizing the sort of fee-for-service model right now, and that helps support some of it, but definitely the backing that our department and hospital have provided has allowed us to sort of continue because there's definitely a deficit. Anyway, it doesn't, as I said, also doesn't allow us to add things that I'd like to do is nutrition. I need at least one, probably more than that, social workers. I think that's one of the challenges is to how to sort of adapt to the changing needs. Now, much of what we do, though, is not billable. That care coordination that everybody's providing, so even if we had 100% return on our fee-for-service, much of it is not billable. It's sort of the off hours and the sort of non-contact or direct patient contact that you're doing. And there are some allowances for care coordination, but again, if the primary pediatrician's utilizing that, I can't extend that or overlap. When it comes to sort of the new models, we've thought about or explored in our hospitals looking more broadly at the ACO models. We can't go at risk for our patients. We're a small program, which, you talk about other programs that are comparable. We've got a targeted population. It's a high-risk population. And we know that no matter what we do, there are things that we don't have control over that is going to necessitate a non-scheduled hospitalization. If we have seizure breakthroughs, we can help them manage some of that at home, but at some point they need to come in. If we have one patient who's in for a couple of weeks and we go at risk for that patient, that literally would sink the entire program probably in terms of charges that we go at risk for. So, our thought is that probably that's not necessarily a viable model to pursue. We're working with one of the payers locally at a possible hybrid model, is to sort of look at, there's a per member per month for our service in general, that with that you get a social worker, you get 24/7 access to a physician via page or telemedicine link. You have sort of scheduled visits, and then on top of that you have the as needed, that you can bill for a fee for service, and so that there's a modicum of sort of payment that helps support the program, and then it's an on-demand type of model.
I get what you're saying. There's this madness of fee for service, and then you come up with a great service. You invented it. It does great things, and yet you can't get it paid for on the one hand. On the other hand, there's big unpredictable risks with your patient population. So it sounds like some hybrid approach is the solution you need.
Yeah, and I have to say, everyone, at face value, people are interested. I mean, I think they appreciate the fact that we've shown some decreased resource utilization, although it shifts, and I think others have looked at this, groups out of Wisconsin and otherwise, have said, okay, we're going to shift from the inpatient service, and there's going to be more outpatient utilization, and there'll be more home care nursing costs, but again, those all pale in comparison to the acute care charges. I mean, the emergency room cost and an ICU cost, that sort of far easily outpace the outpatient cost that may be increased. But it's a challenge that they all look at that and say, families like it, the patients seem to do better, we're not utilizing acute care, but how do we make this happen? And I think this is the barrier, and I'm curious as to what others sort of are working on as well and experiences they've had.
Well, I'll invite those on the audience to send me an email asking to connect with you if they have some thoughts to share along these lines. Perhaps there's some like-minded folks on the phone that are going through something very similar. I'd like to take you back, Rob. You've been at this for 9 years, and we got a great question from one of the people on the call today about outcomes. And I've been, worse before better trajectories and innovation go hand in hand. Nothing ever works perfectly the first time. I wonder if that's something you experienced in the early years and might have a few encouraging words for those who are going through that tough, trying to get your program to work perfectly in the first year sort of stretch of time.
Yes, absolutely. I mean, our first patient was a young man, heart transplant for hypoplastic left heart. He actually went home with peritoneal dialysis and a ventilator for a few reasons, and 2 days later he wound up with RSV and back in the hospital. Obviously I didn't attribute that to our care, but it's definitely a little disheartening, and it certainly, we have an at-risk population. We have probably about a 10% mortality rate amongst our group for either disease progression, unanticipated issues, or actually even just sort of, direct goals of care. That can be challenging emotionally and otherwise, as you do get connected to these families. Honestly, the biggest challenge as I think about this is just, if you aren't on a grant or if you don't have clear funding, is that you're often doing this just on your free time, which I think probably many of the people in the on the attendance can appreciate, is that this is not, this is sort of in addition to your normal job. So my base, as I said, is in the ICU, and so didn't have as much time carved out for this as I would have liked, and so it's a matter of just committing to it and making it work and recognizing that there are other sacrifices that sort of come along with that. My other frustration is really that, I'm trying to approach this both I want to provide the best clinical care. At the same time, I'm trying to pursue the sort of, financing and policy perspective. And then I'm also looking, we're looking to do research to improve the clinical care for our kids, looking at, nutritional studies, working with our infectious disease colleagues on, colonization, differentiating that versus, when do you need to treat, and a number of other things. And so it's the sort of, we always talk about in academia balancing that sort of triad, and it's hard. I mean, it is, there's no way around that.
Does any of the research you're working on today focus on the value that this program provides, quantifying the improvement in outcomes to the extent it's possible to do so against the additional cost of the program?
Yeah, so I actually, when I went to the hospital and to the payer partnership, I was able to partner with phenomenal mentor, Susan Parsons, who runs the Health Institute at Tufts Medical Center. Does a lot of health services research. She's an invaluable resource. And as I said, we've done a lot looking at family-centered outcomes and patient-centered outcomes, but as part of that, we looked at our resource utilization and costs. Hoping to publish that relatively soon. But the challenge we had is, first of all, is, our cost savings are in prevention, so trying to track what did not happen and do that in a valid manner. So we utilized or adapted what was intended for primary care, a care coordination measurement tool. Actually was developed by one of your colleagues up in New Hampshire, along with a general pediatrician who's now here in Boston. And, that allows us to, track our activity, to say, who's doing what, literally how long was each encounter by phone, email, home visit, or otherwise. So, trying to get a sense as to how much expenditure of our own resources we're providing, what's the nature of it, and then really looking at what prevented and what occurred. We know that we are going to send some patients into the ER. We know we're going to refer them to specialists, orthopedics or our ENT ORL colleagues or otherwise, or other subspecialties, or back to the pediatrician. So to say we can't address everything. So we were tracking what did we actually refer them for, and then what do we prevent. And so what we did is, and we continue to do, is actually with each encounter is to say to the family, if you didn't do this, what would have, if we didn't talk to you, what would have happened? And, sort of track, did we prevent an ER visit? Did we prevent a visit to, did we, prescription of an antibiotic? And then we, as part of the analysis, has tried to assign costs to that. Is to use, some of the sort of standard, hospital databases and otherwise where we just assign a cost to an ER visit, a hospitalization, and otherwise, and sort of estimate what our cost savings balance would be. It is challenging because, people, as we present to the insurance companies and even just present to others, we can't really establish a sort of case control. I don't feel like I can do that ethically. I say, okay, we're randomizing you coming out of the ICU. You can have our service and you get standard care with someone else. If someone approaches us, we're happy to provide the care. And it's also hard to say that, how do my patients with SMA compare to someone else's group with spinal muscular atrophy? Because it's so individual. It's dependent on what are their local resources, what's the family's individual goals, and where are they at in their course of their condition.
Do you often get pushback from payers in particular that comes in the form of, well, this isn't a randomized controlled trial, so how do I know this data is accurate?
I think that was, when we present to them on paper, yes. And then you can appreciate actually that they want a rigorous evaluation, and they want to know that we're not gaming the numbers, as it were. Right. But in our sort of face-to-face, as we sort of talk about the challenges in assessing events that didn't happen, and the nuances of this small population, that you can't. One child with muscular dystrophy isn't the same as another child with muscular dystrophy. That I think they do appreciate it, and they've actually all been receptive to this. Again, I think the challenge that we're having with them is that they like the family-centered outcomes. They appreciate the resource and actually cost savings. It's how do we go about doing that? One of the other aspects that we haven't and we're thinking about pursuing as well is extending it and looking at the employers, is to sort of look and sort of start measuring the sort of the time spent away from work for the family, but also the time spent at work dealing with your child or family member's medical needs. It's sort of the it's not necessarily wasted time, but it's not productive time from the employer's standpoint. And so, how do we measure that? Because again, that's one of those intangible costs or unseen costs, I guess. It's certainly not intangible. Them in.
Let's play a game for a second, Robin. Imagine the stars lined up and the funding environment was just right for your program, and now all of a sudden the big challenge was, how do we spread it? You've got 9 years or so of experience doing this in Massachusetts, but certainly there are lots of localities where there's nobody with that's doing care the way that you are. What would it take, given the right financial environment, to really help spread this program?
Yeah, so I think part of it is, it probably needs to be a network. One of the models a lot of people always point to is sort of the CF Foundation, Cystic Fibrosis Foundation sort of model, where you sort of set up standards, and then you've got providers who are interested in it, and then you're providing the clinical care that everyone sort of accepts, and then but you're also continuing to collect clinical information, and whether it be resource utilization or clinical outcomes or otherwise, I think we do need. I said, I don't know that we're doing it right for everyone, and I know that my colleagues around the country, some have other sort of approaches. As I think about some of the active issues, RSV prophylaxis, so the Synagis vaccine, which is certainly costly in terms of administration, but we're not necessarily consistent in our administration, and sometimes we advocate for some of our kids who fall outside the standard sort of criteria, and I'd like to think that helps, but I'm not sure, and I'm not sure without a network and sort of tracking this on a broader scale that we'll know. And maybe we're wrong. Maybe we're actually, by $1,000 a month, we're actually costing the system a lot more money. So I think that's what it's going to have to take. And honestly, I think the feet on the ground are there. I think there are individual providers around the country that are doing this. As I look at the sort of list of attendees today, I'm sure some of them are amongst that group, and I certainly know amongst my colleagues. It's more just a question of if we can get, I was fortunate enough to have some support locally to let me do this, and in the absence of that, it's hard for people to get traction. So I think having a payment mechanism first I think we'll start to see a lot of people interested.
Yeah, interesting question, and right on point just popped up from Tom Mobus. So how often do you have opportunities to learn from your colleagues around the country who are trying to do something similar?
Yeah, so, I have to say part of that is usually around it's disease specific. So I'm very involved in the spinal muscular atrophy community, SMA, and then muscular dystrophy, partially because a lot of the patients we care for have neuromuscular conditions. And so when we meet together, we share angst and challenges, and then try and sort of problem solve with regards to how we can make this work. Because what I find is, as I look at the group out of University of Wisconsin-Madison, certainly down at Children's Hospital of Philadelphia, and where Jack Downs really sort of pioneering, and with Dr. Goldberg down there, everyone struggles with the same things, and so we're all sort of looking for that breakthrough, honestly, in terms of just support making these work.
A related question, so much of what you're doing is dependent on policies made by state governments, Medicaid boards, or Medicare decision makers. Have you seen many chances to influence directly policymaking over the course of your career?
Yeah, I think been able to meet here in Massachusetts with the Secretary of Health and Human Services. We certainly meet with folks. I think it's challenging. They're grappling with other sort of demands. We looked at the mental health services, and those are certainly at the forefront. And I think it's how do you divide the pie, and how much of a long view do you need to take? And if we're looking at, when you introduced this, you talked about targeting small populations. And this actually is probably one of the biggest challenges when we go to state, federal, or third-party payers. Is we're looking at a small number. Granted, as I said, it's a high risk and probably some of the costliest patients as we've worked with the insurers. But the impact for them and their sort of enrollees is small in numbers, maybe big in dollars, but small in numbers. And it's often, if you're targeting mental health, it's a huge number of patients and families that are affected. And so I think, and potentially rightfully so, that's where they're targeting stuff. Or, you look at asthma initiatives or otherwise, you can sort of understand, and you look at adult, you can sort of extrapolate to the adult conditions as well.
Rob, thanks. Been quite a tour we've gone on. I'd love to give you a chance to wrap up, some final reflections, a piece of advice to the audience. Perhaps tell us what's getting you out of bed and having you racing to work every day, or what's most satisfying about your work these days. You've been doing this a long time.
Yeah, honestly, the patients and families are phenomenal. And even if we don't have a good clinical outcome, helping them get, if I can prevent a hospitalization, great. If I have a child who has died or otherwise is helping the family sort of through that, truly, as I'm sure with all of our attendees, it's the patients and families in care that sort of keeps, gets you out of bed and and get you up to respond to that 3 a.m. page. I think that's, I'm going to continue to do this independent of funding mechanisms, as long as we can. I think that goes without saying. I want to make this work on a broader scale because, the other thing that drives me is I know there are a lot of patients who aren't getting the care that I'd like them to get, and I think all of us would like them to get. And the fact is, I think we can make the system work a lot better.
Rob, thanks so much. It's been a pleasure hosting you today. I'm going to work on getting my attendees to raise their hand more often in the future. But I think we should go ahead and wrap up for today. Let me encourage you before you log off to take a look at the chat window. If you're like me, you have a very hard time reading that while simultaneously talking. But there's some interesting comments up there that I think you might enjoy or possibly even benefit from. All the attendees, I appreciate you coming today. I hope you'll come back in another month. I'll announce the end of May seminar shortly, and we hope to keep this up once a month from then on. If you have any feedback at all, we're very, very interested. So as I say goodbye to Rob and thanks so much, I'm going to turn us over to a new screen where you can give us feedback in the form of answers to just 2 questions. I hope you'll do that, and we look forward to seeing you next time. Thank you all so very much for joining us.